Many oral and maxillofacial surgeons provide anesthesia to pediatric patients in their office. The youngest child whom the OMS will treat must be determined by each OMS based on individual training, experience, appropriately sized equipment, and availability of trained staff.
How old is she?
A thorough history and physical exam should be performed at the consultation visit in order to establish an appropriate plan for anesthesia and surgery. Documenting the child's weight in kilograms at the consultation visit allows emergency drug doses to be determined and available on the anesthesia record on the day of surgery. For those children with medical problems, such as asthma, obesity, and other systemic conditions, consultation with the child's physician may be valuable.
Okay, Kaylee, I'm just going to take a look inside your mouth, see what's going on there.
On the day of surgery, the OMS should obtain a recent history from the parent, with particular attention to respiratory tract symptoms, and perform a physical examination with close attention to the airway and respiration. The anatomy of a child's airway exhibits 6 major differences from that of an adult. First, the tongue is larger in proportion to the mouth and is prone to obstruction. Second, the pharynx is smaller. Third, the epiglottis is larger and floppier and angled away from the axis of the trachea, making visualization more difficult. Fourth, the larynx is higher in the neck and decreases the airway space, predisposing the patient to obstruction. Fifth, the airway is narrowest at the cricoid. Trauma to this area may cause airway edema and obstruction. Sixth, the trachea is narrow and less rigid. Close observation of the pediatric airway is crucial in successful anesthesia delivery.
It's going to be very easy for you. Have you had anything to eat or drink this morning?
Yes.
About what time?
Adherence to the ASA fasting recommendations prevents the child from becoming overly thirsty and provides physiological benefits, such as decreased incidence of hypotension and hypoglycemia. These recommendations include fasting from meat, fatty, and fried foods for at least 8 hours, and fasting for at least 6 hours from a light meal, such as toast and clear liquids and non-human milk. Both the amount and type of food ingested should be ascertained when determining an appropriate fasting period.
What we're going to do, Kaylee, is we're going to
Explanation of what will take place is important in diffusing stress for the child patient. A child who is appropriately prepared by the staff and parents can often tolerate placement of an IV or mask induction. The anxious child may require preoperative sedation. Oral midazolam can be administered 20 to 45 minutes before induction. Another effective oral premedication is clonidine. If oral premeds are given, the dose should be administered in the office and under monitored care. In accordance with the AAOMS parameters of care, monitoring of oxygenation, ventilation, and circulation are required for moderate sedation, deep sedation, and general anesthesia. Some form of temperature monitor is encouraged for all children and is required if the child receives triggering agents for malignant hyperthermia. Because of the rapidity at which children decompensate, capnography is an extremely useful tool, and beginning in January 2014 will be a required part of the AAOMS office anesthesia evaluation. In most pediatric emergencies, the algorithms established for adults can be followed with minor changes, most of which involve proper pediatric doses. AAOMS recommends a separate pediatric ring binder in the emergency cart with pediatric-specific dosing. A Brosolo tape may be used to estimate the weight of the child pre-procedure. The anesthesia team should also consider PALS certification. Pediatric Anesthesia Summary. On day of surgery, obtain recent history and perform physical examination with particular attention to respiratory tract symptoms. Be mindful of the major anatomic differences between the adult and child airway. Adhere to ASA fasting recommendations. Behavior management includes psychological techniques by the parent and the anesthesia team and may include preoperative sedatives. Monitor the patient's vital signs and closely observe the airway throughout the procedure and recovery. Maintain a pediatric binder in the emergency cart with appropriate pediatric dosing regimens. Consider PALS certification for the anesthesia team members.